So this is basic management of common childhood illnesses. Um, and so a lot of bread and butter pediatrics, just basic pediatric questions and those kind of things and topics. So this is one of those lectures where we're going to hit like really fast, really hard, and not have extensive lecture about things. So an example being on Wednesday, I'm probably going to give you another lecture on neonatal sepsis. And so there may be something about neonatal sepsis here, but it'll be 1 or 2 slides just to hit the high points. Does that make sense? A lot of outpatient pediatrics and some of those things too here, okay? All right, so really bread and butter pediatrics. So, you'll, if you're here in the presentation, you're going to have the results of the answers up on the screen because I can't really help that. So this is a result of, you see the little things on the hair shafts there. And a lot of my pictures that I have are on Caucasians just because the things show up a little bit easier on Caucasians than Africans. But at the same time, the teaching point is good. So 1, dry scalp, 2, pediculosis capitis, 3, pediculosis corporis, or seborrheic dermatitis. What do y'all think? Pediculosis capitis. So head lice is what pediculosis capitis is. Head lice can cause louse-borne typhus, HIV, AIDS, trench fever, or none of the above. Yeah, so kind of a trick question there, right? None of the above is the answer. So head lice really are not disease vectors. It grosses everybody out, right? Everybody freaks out when they hear somebody has head lice. But head lice cannot transfer any type of disease vector to anyone else. And so when you treat, if a shampoo containing lindane or permethrin is available for the treatment of lice, you could recommend, if it's not available, you would recommend gasoline, kerosene, vinegar and oil, shaving the head, or fine combing the hair daily for 3 to 10 minutes times 14 days. Yeah, so here shaving is one of those things, but really fine combing is all you need. Now, if you have hair extensions and some of those things, then you probably can't fine comb that, right? So you're gonna have to get rid of those before you look at doing anything else. But you don't have to shave the head, so that's important for females, right? So females that have long hair, or even males, I guess, you don't have to shave the head. Just fine combing with a very fine tooth comb, 3 to 10 minutes for 2 weeks will really help out. So pediculosis capitis, head lice. So I'm going to kind of skip this and go to the next one because it's a good life cycle there that you can see. So day 0, the egg is laid. Day 6 through to 7, the louse hatches between 6 to 10 days. And then day 8 and 9, the first molt occurs. And then day 11 to 12, the second molt occurs. And then you have a third molt occurs, day 16 to 17. All right, and then you have adults around day 17 or 18 that then can start mating again, and you kind of start that process all over again. So that's the life cycle of a head lice. And so clinical symptoms can be asymptomatic. They can have a lot of itching, like y'all are all scratching your heads now, so itching on the back, especially around the nape of the neck here or back of the ears. They can have a lot of itching there. You can have excoriations. You can have regional lymphadenopathy associated with it. So treatment usually is permethrin treatment, 1%. And so you repeat that after 1 week. And the reason is because if you watch what that life cycle was, all the eggs hatch after 1 week, right? And so your permethrin or your lindane and things aren't going to penetrate that egg. And so you need those eggs to hatch and then kill the nymphs or the adults at that point, all right? And so malathion, lindane are second-line therapies, and then oral ivermectin if that's available and you need it. All right. This hair pattern is caused by 1, impetigo, 2, seborrheic dermatitis, 3, tinea capitis, or 4, trichotillomania. What do y'all think? Yeah, tinea capitis, right? What's trichotillomania? No, trichotillomania is actually is actually a mental disorder. So so trichotillomania is when someone actually eats their hair. And so a lot of times on females that have long hair, you'll see a female kind of chewing their hair all the time and some of those things. So if you do that a lot and you're eating your hair, then you get bald spots in particular areas because they're pulling their hair out and eating it, okay? So it's a mental disorder. But this one is actually caused by tinea capitis. And what is tinea capitis? Ringworm, right? All right, so ringworm of the scalp. It's a fungal infection of the scalp. You have patchy areas of scaling. So you'll get this dry, patchy scaling. It won't be a complete bald spot. That's why you have this black dot inside. That's because you have the base of the hairs that are still there. All right, and so you'll have this patchiness with some hair within that area. Right, can be confused with dandruff, seborrhea, eczema, alopecia, those kind of things. So the broken hairs where you get the black dot ringworm kind of phrase from. They can have pustules or excoriations there, as you see on that bottom picture. That's a carrion, so that's an boggy inflammatory mass, all right? So if a child has a lot of ringworms of the scalp, they're probably going to have some carrions available. Carrion's not actually the fungus causing that infection. It's actually your body reacting to the fungus. So it's a hypersensitivity reaction to that fungus made up of inflammatory cells, so neutrophils and those kind of things. And you can have some regional local lymphadenopathy. It can be really tender, and to treat that, you need to treat the tinea capitis. And so it's most likely caused by trichophyton or microsporum. It is direct contact or fomites. So if you share combs, share razors, go to the barbershop that has fungi infection on their scissors and things, you can certainly get it from that area. So you need to make sure the places are real clean with the tools you use for your hair. Usually just examination. Sometimes you can do a culture if you really need to have something hard to get. And then topical treatment. So selenium sulfite or ketoconazole shampoos. These help reduce the transmission and reduce the itchiness. Here, if you can shave real close to the skin, then you can possibly use the topical antifungals. Keep in mind you need to disinfect that razor because it's going to be able to transmit that fungus as well, okay? But if you can shave the head really close, then you can use a topical antifungal. Otherwise, if there's any signs of hair there, you need to use oral griseofulvin, okay? 20 milligrams per kilogram daily for 6 weeks. You treat for at least 2 weeks after the resolution of that ringworm of the scalp. And then don't share personal items. You can also have ringworm of the body. That's trichophyton, and that's usually the face, the trunk, the limbs. You have a circular raised erythematous area with scaling borders. So you have that scale. You see that scale in that picture in the middle with the red erythematous raised borders. Is pretty common for ringworm. Direct contact also can share this disease. And topical antifungals such as clotrimazole, ketoconazole, and those kind of things are what we use to treat it. And then you have ringworm or athlete's foot of the foot, and so you see these red, itchy, really burning areas of the feet. They get into the toenails and they can turn them black, usually in older children or teens associated with this. It's really uncommon in younger children. Once again, it is contagious, and you use oral antifungal if you don't have any topical treatment to use. Your first morning void is usually pretty acidic, and so it can actually treat. And so oftentimes you'll hear people tell you to pee on your feet or use the urine from your very first morning void to help treat tinea pedis or athlete's foot. All right, my baby's got dandruff. So this white scaly lesions on the scalp, is this tinea capitis, eczema, cradle cap, or dandruff? Cradle cap, right? Yeah, I agree, cradle cap. So what's cradle cap? It's seborrhea dermatitis. We don't really know what causes this. We think it's Malassezia furfur. It's possibly associated with some vitamin or nutritional deficiencies as well. Usually it's non-paritic. There's a greasy, scaly scalp. It's usually self-limited, so you don't have to treat it. If you want to treat it, use an antifungal shampoo like ketoconazole. You can also use an anti-dandruff shampoo, okay? I don't know what those are here, but any type of anti-dandruff shampoo you can get at the store also usually has enough to be able to treat that. Hydrocortisone ointment if you really need to. Lead poisoning, so this is something you got to think about, especially if lead-based paints are still used currently, or if they're used in an older house where there's flakes of paint in the dirt or around a housing or something like that. So children can eat the dirt, they can eat the paint chips, they can suck on toys that are made that are painted with lead-based paint, and then they can get lead poisoning. So something to think about. They have neurocognitive development, behavioral issues, microcytic hypochromic anemia, and it can affect the bone structures. So these children present with headache, constipation, abdominal pain, malaise. When you examine them, they're really they have pale skin. They can have a stupor, or they can be a little bit off balance. And then the lead lines are these dark lines on the gums. And so really dark lines on the gums tend to show signs of lead lines. If you can do a blood lead level, I don't know if we can do that here or not, even at send out. I know we can't do it at Kajabi. Then that's a possibility. And then if it's over 45, then you want to consider chelation therapy. All right, what's this one? 6-year-old female presents with severe headache, vomiting, fever, and to 40 degrees and a seizure with this rash. What do y'all think that is? Yeah, meningococcemia, right? So most likely organism there, we already said the answer, Neisseria meningitis. All right, so bacterial meningitis in kids. So the most common, less than 1 month, is E. coli. Second is Group B strep. We don't do Group B strep screens here, but it's still the second most common signs of bacterial meningitis in young babies. Then we have our Klebsiella and Listeria. Once you get to 1 to 3 months, then GBS kind of comes back to the top. You also have E. coli, strep pneumo, and Neisseria starts in there if they're unvaccinated, which you would have to catch the vaccine pretty quick, but H. flu then can be a problem. Over 3 months, strep pneumo easily is the most common, and then Neisseria meningitis, unimmunized H. flu, and then remember some of the other stuff like malaria, TB, HIV, everything else, okay? So symptoms and signs: fever, increased ICP, irritability, lethargy, they can have vomiting, seizures, confusion, anything like that. Here especially, we do a pretty good job of thinking about bacterial meningitis, to be honest. Meningococcemia definitely can have that rash that you saw there, focal CNS deficits, and meningismus. So typically white blood cells are over 1,000. I know we treat a lot smaller here. One of the reasons we do that is because we don't have automated machines, so someone actually has to look at it, and it's per high-powered field. And so we're not certain specifically how many white blood cells equal to bacterial meningitis. Our cultures aren't great here either in CSF, and so we need to improve upon that, but that's the reason that we treat a lot lower than what you would typically see. But when you think about bacterial meningitis, typically you would think about thousands, tens of thousands white blood cells in that CSF, okay? Protein is high, glucose is low. If they're less than 6 weeks, you make sure you do all your cultures, not just CSF, okay? You need to make sure you have everything there. So treatment, if they're less than 4 weeks of age, ampicillin plus gentamicin or cefotaxime. If they're over 4 weeks of age, then you would do a 3rd-generation cephalosporin plus vancomycin. If they're really ill, that's when you want to add vancomycin into there. Steroids are controversial. However, if you can get those steroids in either before your antibiotics or right after your antibiotics, in adults, steroids have proven to show benefit for strep pneumomeningitis. Also, obviously, if the patient has TB, then steroids are something that we use with TB meningitis pretty commonly. Morbidity, the most common morbidity associated with bacterial meningitis is hearing loss. So if you are treating any child for meningitis, then you absolutely need to check the hearing before they're discharged. Any questions? All right, febrile seizures. Simple febrile seizures last less than 15 minutes. They're typically generalized. They typically don't have any focal neurological findings associated, They spontaneously resolve and they don't recur within 24 hours. That's simple. When you get into a complex febrile seizure, it's over 15 minutes. It may be multiple back to back, so greater than one seizure within 24 hours, and they can have focal neurological findings associated with them. You're talking about 3 months to 5 years for febrile seizures. Most high time frame is 12 to 18 months of life. 2 to 4% of children less than 5 have febrile seizures, okay? It's usually associated with fever, associated with some other illness, so upper respiratory tract infection, ear infections, viral infections, UTIs, something of the sort, even vaccines. Family history is really important because 10 to 20% of patients that have febrile seizures that will go on to have other family members that also have febrile seizures. And then 30% recurrence rate if you've had a febrile seizure before of having another one. So you want to do a thorough history and physical, find out if there's any signs of meningitis, see if you can identify a cause of fever. Because if they've had a simple febrile seizure, they may not need any workup at all. They may not need a lumbar puncture, they may not need imaging, they may not need an EEG or anything like that. So simple febrile seizures, neuroimaging is usually not indicated, nor is an EEG. You want to consider your other labs to see if you can find that source of infection. You want to treat any identifiable cause and then educate and reassure the parents. So the importance that they need to know is 1/3 or 30% have recurrence, okay? 50% usually reoccur within 1 year, and 90% of the time will have that reoccurrence within 2 years if they're going to have it. The younger they have febrile seizures, the more likely they are to have that recurrence. So what percentage of the population has seizures? Exactly. Great. So I don't know if that was a guess or not, but 1%. 1% is true. So as you can see, someone with simple febrile seizures really has about the same percentage of going on to have epilepsy as anybody else walking around that's never had it, right? And so that's the one thing that you need to kind of reassure the parents is they really don't have that much more of a likelihood of having seizure disorder as anybody else does, all right? All right, what is the most common cause of conjunctivitis in children? Allergies, bacteria, virus, or chemicals? Herpes? No, that's not the most common, but viruses in general are the most common cause of conjunctivitis in children, all right? So non-infectious, think of allergic conjunctivitis or non-allergic such as foreign bodies or chemicals or something like that. Infectious, think of bacterial or viral. Bacterial conjunctivitis are much more common in children than they are in kids. Staph aureus being the most common cause, and then think about the other bugs that cause ear infections. So strep pneumo, non-typable H flu, moraxella, those kind of things. Direct contact or fomites. This is very, very contagious, and so you really want, before you send them back to daycare or being around other kids or something of the sort, you really want them to be on antibiotics for at least 24 hours before they go back. They have erythema, unilateral versus bilateral conjunctivitis, and discharge, and then usually with bacterial conjunctivitis, there's copious purulent discharge involved. So you can see these pictures here. The bilateral or unilateral, very red conjunctiva with this yellow nasty discharge that's associated. So you want to use a topical antibiotic ointment, no steroids, okay? That's very important, no steroids. In fact, I would say never give steroids to be put in the eye unless an ophthalmologist is seeing that person, okay? So no steroids, and then 3 to 4 times a day, topical antibiotics. Viral conjunctivitis usually is adenovirus, all right? Look for other viral symptoms such as fever, rhinorrhea, lymphadenopathy, rash, etc. Erythema, once again, it can be unilateral, it can be bilateral. They have more of a watery mucoserous discharge versus this purulent type of discharge. And viral conjunctivitis obviously is self-limited. It's really hard to tell the difference though most of the time, and so usually we treat with antibiotics either way. All right, which one of the following is not a common cause of bacterial acute otitis media? Staph aureus, strep pneumo, non-typable H flu, or moraxella? Yeah, Staph aureus. That's not a real common cause of acute otitis media. Acute otitis media mainly caused by strep pneumo, and then you have these other things too, okay? Pain control is the key, so you want to give paracetamol, you want to give ibuprofen, and some of those topical antipyretics and pain control. Children over 2, you can observe for 48 to 72 hours. You don't have to treat automatically, okay? Because most of the time they can get better on their own. Most of the time, 80% of the time, in fact, it's viral, okay? So most of the time it's not a bacterial cause. However, they have to have good follow-up, and you have to be able to see them within 48 hours. So you treat them with pain control, you send them home, you have them come back in 48 hours. If it's still red and inflamed like a ear infection, then you go ahead and treat them. First line is amoxicillin, high dose amoxicillin, so 80 to 90 milligrams per kilogram per day. Why do we use high dose amoxicillin? Overcome beta-lactamase resistance, okay? So strep pneumo has high beta-lactamase resistance, and normal doses of amoxicillin of the 50 per kilo per day won't do it. So you got to get up to 80 to 90 per kilo per day. Same is true with Augmentin, okay? You need to have 80 to 90 mg per kg per day of the amoxicillin component for Augmentin when you prescribe that. Ceftriaxone for 2 to 3 days typically is enough to treat ear infections. So if you're in the hospital and they have an ear infection, you're on ceftriaxone, that should be enough, okay? Pain while pulling the earlobe is not usually a good indicator unless they're older, because toddlers, like around 12 months to 24 months or something like that, they're still exploring. So for them to identify my right ear hurts, I tug on my right ear, and that's because there's pain there, is pretty low likelihood of sensitivity for acute otitis media. All right, a 9-month-old with watery red eyes, clear nasal drainage, and cough most likely has viral URI, seasonal allergies, COVID-19, or sinus infection. Correct. Viral URI, not speaking of COVID, right? All right, so allergic rhinitis. We'll talk about allergic rhinitis real quick. It's IgE-mediated rhinoconjunctivitis. It's usually associated with eczema and asthma as well. It's rare in kids less than 2. Why? Because they have to be exposed to that allergen, build up an antibody response to that allergen, and then get re-exposed. That leads to the allergic rhinitis, okay? So usually kids less than about 15 months or so cannot really have allergies unless they're continuously being re-exposed to whatever allergen you think may be going on. Their nasal turbinates can be pale and boggy and swollen. They can have problems with smelling. They can breathe out of their mouth if it's really swollen all the time. If you look at the back of their throat, they have postnasal drip and cobblestoning and streaking. All right, symptoms: itchy, watery eyes, sneezing, stuffy, runny nose. So treatment, avoid the allergy if possible, and then your first line treatment should be intranasal steroids such as beclomethasone spray, okay? So not cetirizine or something like that. That should be more of a second line treatment. You want to topically get right on that with that steroids if possible. And the intranasal antihistamines, oral steroids, and then consider allergy shots if they're having a lot of problems. The most common site for group A strep infection is heart, joints, muscle, throat, or skin. Throat, right. I was trying to throw you off there with that rash. Group A strep pharyngitis. So 1 to 3 years old usually has upper respiratory tract infections, all right? Rhinitis, fever, anorexia. Acute strep pharyngitis in a kid less than 3 is really pretty rare, all right? So you need to be thinking twice before you diagnose them with strep pharyngitis if they're less than 3. Acute rheumatic fever secondary to strep is extremely rare in kids less than 3. We can't really test with rapid streps here, so it is kind of more of a visual diagnosis. What I would say is if they have symptoms of virus, they have a runny nose, if they have cough and congestion or any respiratory symptoms, it is much more likely to be viral than actual strep pharyngitis, all right? So just think about that. Classic strep pharyngitis, kid over 3, fever, headache, abdominal pain, and acute pharyngitis. All right, they don't want to eat because it hurts too bad to eat. Sometimes they don't want to even drink because it hurts so bad. URI symptoms such as runny nose and such is not present. Treatment, penicillin, you can give one-time dose of IM penicillin and it treats it. All right, make sure they don't have a penicillin allergy. This is a parent-friendly regimen because they don't have to try to force 10 days of antibiotics down some kid. All right, and so, but I know here especially y'all don't like shots very much, and so most of the time here parents will choose to give oral antibiotics. Amoxicillin can be given low dose. It can be given once a day unless it's too high of a volume, and it's treated for 10 days. There are some resistance to azithromycin, and so we don't typically use that as much. I know y'all use that in adults a little bit more frequently. So. Clarithromycin, yeah, those things work too. It's fine. Scarlet fever. Skin is the second most common site of group A strep infections. You have this red erythematous sandpaper-like rash. They can have other group A strep type of symptoms. It's treated the same way, and they can go ahead and develop acute glomerulonephritis as well. Which one of the following is not a major Jones criteria in the diagnosis of rheumatic fever? Polyarthritis, elevated white count, carditis, St. Vitus's dance, or erythema marginatum? Yeah, exactly. Elevated white cell count is not a major criteria. So think of Jones criteria, you can spell it out with Jones. So joints, migratory polyarthritis, 75% of the time they have it. Heart conditions or carditis, 50% of the times they have that. Nodules, so subcutaneous nodules. I have pictures of all these y'all can see. Erythema marginatum, Sydenham's chorea, which is otherwise known as St. Vitus's dance, all right, 10% of the time. And then your minor criteria, fever, arthralgias, elevated CRP or ESR, leukocytosis, EKG with a heart block, and then positive ASO titers. Okay, acute rheumatic fever. You can see there that dark blue, 5 to 7 cases per 1,000, right there in the middle of lower sub-Saharan Africa, right? And so very common here. Subcutaneous nodules, you can see that nodule just under the skin there. Erythema marginatum, so they oftentimes have this rash that looks a little bit like tinea, so you kind of need to ask that question. Erythema marginatum there. Acute rheumatic fever affects 20 million people worldwide. It is the leading cause of cardiovascular death in people under 50. Most cases occur in 5 to 15-year-olds. It's rare in children less than 3. We've already mentioned that. So fever, malaise, arthralgia, and weak. They have an arthritis and a myocarditis, which is reversible. Valvular disease is not. And so I know Tenwick, they do a lot of surgeries for acute rheumatic fever. And I think there's a lot more common school screening programs now, isn't there? And so we're going to be able to identify these a lot better now. Treatment, you want to eliminate the group A strep infection. So even if they already have signs of valvular disease and you identify the infection from months ago, if they haven't been treated with a course of antibiotics, you want to go ahead and make sure that's done. Alleviate any symptoms they may have, and then prophylaxis recommendations if they have valvular heart disease. Treatment is just penicillin for 10 days. You can use erythromycin, aspirin if they have heart disease, and then prevention of it is the key. So if you suspect group A strep pharyngitis in kids over 3, you want to treat it. Okay, have a low threshold of doing that. 4-month-old presents with tachypnea, retractions, and wheezing. What is the most likely cause? Pneumonia, foreign body, bronchiolitis, asthma, or COVID-19? So the age is the key here, okay? So 4-month-old with tachypnea, retraction, and wheezing is most likely going to be a viral bronchiolitis, all right? I know we treat a lot of pneumonias here, but still bronchiolitis is the most common cause of respiratory defects in kids. Usually in the cooler months of wherever you are at, so usually going to be more of the winter months or cooler months, usually less than 24 months of age. 2 to 6 months is the most common time frame. Viral, it is viral, so RSV being the most common cause, parainfluenza, adenovirus, influenza, and human metapneumovirus we just discovered maybe 10 years ago or so, and it's a common cause. Contact with secretion. So I kind of made a big deal out of this a month or so ago when we were putting PPE in place for COVID-19. And really, other than the face shield and the need for N95 if you're doing respiratory procedures, it is the same PPE prophylaxis for bronchiolitis, all right? So we just haven't been very good about doing this. Contact droplet PPE prophylaxis is needed for bronchiolitis because it's really contagious, okay? RSV bronchiolitis is the most common cause of bronchiolitis and pneumonia in infants. Rhinorrhea, cough, fever, wheeze, tachypnea. Clinical diagnosis, if they have a rapid one, you don't have to do that just because it's viral. So who cares which virus is causing it? It's viral, right? Less than 1% mortality. It's supportive care, so oxygen, suctioning, albuterol, racemic epinephrine, hypertonic saline. Steroids, antibiotics really haven't been proven any benefit, but nothing has, right? Nothing's been shown to be effective. Every few years, something new comes up to treat bronchiolitis, and we try it, and then overall, once they do a bunch of testing, usually it pans out to not really be that effective. So all I would say to that is, it's worth a try, right? If you hear wheezing, it's worth a try to give a dose of salbutamol and see if it helps. If it helps, great. If it doesn't, don't use it, all right? Same thing with the 3% NEMS or whatever, all right? Usually self-resolve. Days 3 to 5 tend to be the worst. So this is one of those cases you really need to find when did that cough and congestion start, because then you gotta know. Then you're going to know a little bit more about when it's going to be worse. So if you got a 1-month-old that's on day 1 or 2 of illness, is already breathing 50 times a minute, the chances are they're going to get worse before they get better. So you don't want to send them back out 3 hours from healthcare facility, okay? So it's really important to know where they're at within that illness. Synagis is a vaccine. It's super, super expensive. You can get it in Kenya, but it's really, really expensive. What is the first respiratory sign of pneumonia in children? Cyanosis, nasal flaring, subcostal retractions, tachypnea, or wheezing. Tachypnea, right? All right. Pneumonia in children. One of the main causes of mortality in developing countries and morbidity in developed countries. Once again, more prevalent in cold months. It is airborne in transmission. So risk factors for pneumonia: lower socioeconomic groups, school age, status, cardiopulmonary disorders, and smoke exposure. Vaccines are really highly protective against pneumonia. So H-flu vaccine, pneumococcal vaccine, all those kind of things. Etiology, strep pneumo being the most common cause, but also group A strep, H-flu, mycoplasma, Staph aureus, and viruses and such, okay? Symptoms, just like with bronchiolitis, fever, cough, distress. They may not have as much nasal drainage and some of those other viral symptoms. Vocal crackles, decreased breath sounds in that focal area of whichever side it's on, and rhonchi. So diagnosis is by chest x-ray. If they're really sick with high fevers, especially need to be hospitalized, that's when you consider doing a blood culture. Otherwise, you don't have to treat outpatient pneumonia with the blood culture. And then pleural fluid, obviously, if they have any type of complication. So treatment for pneumonia, outpatient, 5 to 7 days of therapy. If they're 4 months to 4 years of age, amoxicillin and cephalosporin, plus or minus flagyl or clindamycin if they've had signs of aspiration. If they're over 5 years of age, macrolide is usually added to the regimen. So macrolide is recommended in all adults, right? So I usually think of macrolide therapy for walking pneumonia. Mycoplasma pneumonia is otherwise known as walking pneumonia. So think about it is if they're walking to school, so y'all start school a little bit earlier here, maybe 3, 4 years of age sometimes, right? So if they're walking to school, you want to think about walking pneumonia, and that's when you add zithromycin, okay? Inpatient treatment, usually more like 7 to 10 days. Really depends on why they need to be admitted and what workup you need to do. You can use ampicillin or penicillin, cephalosporins, piptazo or clindamycin or flagyl are added for aspiration type of symptoms, and then macrolides are also used inpatient as well. The noise from wheezing is, 1, extrathoracic and on exhalation, extrathoracic and on inspiration, intrathoracic and on exhalation, or intrathoracic and on inspiration. Right, intrathoracic on exhalation, okay? That's where wheezing is, versus stridor is extrathoracic on inhalation, right? All right, asthma. So asthma affects 339 million people worldwide. In 2016, it was the 16th leading cause of death worldwide. It's the most common chronic disease in children. It occurs in all countries, regardless of level of development. 80% of asthma deaths, however, occur in low-income countries. Asthma is very underdiagnosed and very undertreated. Right? Something that we need to do much better at in our treatment. Substantial burden to individuals and families and restricts activities for the lifetime. So here, that top picture there is a perfect example of how not to do it, right? So if you put that inhaler directly into the mouth, you swallow at least 80 to 90% of the medicine. So you really have to provide a spacer to anybody using an inhaler regardless, all right? It's a chronic disease. They have cough and chest pain, wheezing, dyspnea. It can be exacerbated by illness or exercise, allergens, weather changes, smoke. Their attacks can vary in severity and frequency, and control is the key. So reactive treatment of asthma is not a good thing. You want control. You want to prevent them from having attacks. So acute attack is treated with short-acting beta agonists. Maintenance is treated with inhaled steroids like beclomethasone, okay? Long-acting beta agonists, that's when you add salmeterol or something like that to the regimen, okay? Leukotriene modifiers, such as montelukast, is a second-line treatment. Oral steroids when they have an acute exacerbation as well, and then avoid any triggers such as cooking with smoke or smoking or things like that, right? So treatment is the key. So if you have a patient with asthma, they need to be coming back to see you every 2 to 4 months to see how they're doing so that you can escalate their control as needed. All right. Asthma management, antibiotic won't play a role at all. However, if a child has pneumonia or something like that, they can certainly have acute asthma exacerbation associated with that too. So you may have to treat both. Does that make sense? All right, why is my baby yellow? Jaundice, topical folk remedy, eating too many lemons, played in the paint. Jaundice, right? Yeah, something we see a lot here. Neonatal jaundice, there's a whole lecture associated with this, so I don't want to go too deep into it. All right, 50 to 60% of all newborns have jaundice. Physiological jaundice is the most common. It is always pathologic if it's within the first 24 hours of life, if it's rising by 5 milligrams per day, or direct greater than 2. Anytime those three things happen, it's pathologic. You need to figure out what's going on and treat it. Breast milk jaundice happens in 1% of breastfed infants. It's usually later onset, such as 7 to 10 days of life. Rule out other causes. It does not progress. Hold breastfeeding for 24 to 48 hours. Give formula, and that will treat it. If you need to, you can just breastfeed through. You don't have to treat it if you don't want to. Physiological jaundice, high red blood cell turnover, immature liver function. So usually presents at 2 to 7 days of life. You usually have an unconjugated hyperbilirubinemia. Jaundice is seen at these levels. So at 5, you start seeing it in the face. At 7, it kind of gets down to the nipple line. At 10, down to the umbilicus. 15, into the groin and hands and feet if it's up around 20, okay? Obviously, this is in milligrams per deciliter, not millimoles per liter. Physiological jaundice, treatment for it, eat, pee, and poop, all right? So good history of, is mom's breast milk in? Is the baby latching good? Is the baby peeing and pooping? What color is the stool? All those things are important questions on a baby with jaundice. Treatments based upon the age and their risk factors based upon the curve, okay? Treatment most commonly is phototherapy. We use IVIG here if there's a hemolytic process going on, and then exchange transfusion to prevent kernicterus is key. Monitor your trends, so how fast is it rising, and monitor your bounce levels if you've stopped your phototherapy. Make sure it doesn't start rising too fast. So you see that picture up there on the left? What is that trying to treat? It's a folk remedy for what? Colic, hernia, constipation, or she's fat? Yeah, exactly, colic. All right, colic. Normal crying, 45 minutes to 2 hours per day. So are any of y'all parents that are here? No? So these are babies that cry for 2 hours straight, and you can't do anything to make them stop. Okay? Obviously, the parents are really, really worried about that, and colic is a diagnosis of exclusion. Okay? You can't automatically say there's colic if you haven't excluded other things. Usually remember 3, so usually starts at 3 weeks, it goes until they're 3 months, and then it just stops, all right? So if you got a 6-month-old that's crying for 2 hours a day, it's probably not colic. There's probably something else going on, all right? Difficult to console. You can try anything such as this next slide is showing you. It's a busy slide. I'm not going to go into that, but these are things that have been tried to help with colic. Some of them help a little, some of them don't. You just do anything you can. Usually the parents can find something that calms the baby down a little bit, and then they go with that. But you just got to push through until it goes away at around 3 months. Constipation, most common cause of acute abdominal pain in children. It's the most common outpatient visit for acute abdominal pain in children, and the most common admission criteria for acute abdominal pain in children. So it's super, super common thing that we see. Usually associated more with poor fiber diets, which is becoming more prominent here in Kenya. All right, it's a Western type of diet, but it's becoming more and more prominent here. Low water intake, low physical activity, poor stooling habits. Consider anatomical and functional causes. They have this vague abdominal pain that may become very, very severe when they're having squeezing. So when peristalsis happens, that bowel gut squeezes upon very hard stool. As you know, bowel is very, very sensitive, right? And so if that bowel is trying to squeeze on really hard stool, it can hurt really, really bad. So they may present like an acute abdomen, but then in hindsight, it ends up just being constipation. So vomiting, cramping, acute onset and associations, and then get a good stooling history. It's a clinical diagnosis. You can consider abdominal x-ray. And treatment is dietary modification. So lots more water. Try to limit dairy products. Try to limit milk products, cheeses, things like that. Low banana intake, and then increase your fiber. So fresh fruits and vegetables, nuts, high fiber intake, a lot of water. And then at the very end, you can start looking at other things like stool softeners, laxatives, enemas, and things like that. Sometimes patients need admission to the hospital for a clean out to kind of get them restarted. Helminthic infections affect up to 90% of school-aged children in some areas. It contributes to malnutrition and iron deficiency anemia. It may make the host more susceptible to HIV and hasten their viral loads. You want to be on top of it in those populations. And treatment has been felt to improve school performance and cognitive function. So you want to treat for helminthic infections periodically, okay? If they haven't been treating, so example in our SAM protocol, we treat for helminthic type of infections, right? At about 7 days, they're supposed to get albendazole or mebendazole treatment. It's a periodic treatment of worms. Pinworms, Enterobius vermicularis. Do y'all know what pinworms are? You do? All right. So these are these toddlers or kids that have this itchy anus, usually at nighttime. If you look in there, then you can actually see the worms in their anus, little pinworms coming out. All right. Really common. It can cause them to have problems with sleeping and abdominal pain. The Scotch tape test, basically, if you put Scotch tape on their anus and then pull it off, some of the worms come out with it. You really got to be at nighttime, though, to be able to do that. Treatment is just albendazole, mebendazole, and you want to probably repeat in 2 weeks once again to get those eggs hatched and then treat those new adults. Umbilical hernias are more common in the black race and females. Mostly they will close by 5. So pretty common presentation and very common for us to say, go home. It should close by 5. If it doesn't close by 5, we'll get you to a pediatric surgeon at that point. All right. If they're less than 2 centimeters, over 90% close, 85% overall closure, and then surgical closure over 5 if it's not needed. Don't put anything over it. Don't try to force it in, things like that, because it doesn't work, all right? It doesn't hasten it, and it can cause strangulation. Keep in mind, as that hole starts closing, you get smaller and smaller. If you have bowel outside, that's the risk of herniation at that point and strangulation. And so that's when you would want to maybe think a little bit more seriously about making sure there's not strangulation there. What is the first sign of dehydration in children? Tachycardia, tachypnea, prolonged cap refill, or decreased urine output? Right, remember that. All right, diarrhea, second leading cause of death globally in children less than 5. Nearly 1 in 5 child deaths, 525,000 deaths per year, 1.7 billion childhood cases of diarrhea per year. So really dramatic and really a problem. Kills more children than AIDS, malaria, and measles combined. All right. It's a leading cause of malnutrition as well. Most episodes are mild and acute. Most deaths occur in children due to dehydration, so losing large quantities of water, not seeking medical care, loss of electrolytes, and such. Diarrhea, so rotavirus still is the leading cause of acute diarrhea in children. We don't really have a test that's easy for that here. 40% of all hospitalizations worldwide. This has changed with the vaccine. So this vaccine, rotavirus vaccine, was actually developed my second year of pediatric residency. So my first year of pediatric residency as an intern, I bet I admitted 100 to 300 cases of rotavirus to the hospital. And then my second year, it got less. And then my third year, after the rotavirus vaccine had been around for an entire year, I haven't admitted 10 cases since. All right. So that's how dramatic and effective this vaccine has been for rotavirus. So very, very important vaccine. Do we get that vaccine here? We do, right? Yeah. Okay. Bacterial pathogens: E. coli, Salmonella, Shigella, Campylobacter, and Vibrio cholera. Cryptosporidium is the most frequent protozoan among children, especially in HIV-positive patients. So diarrhea, acute watery diarrhea has significant fluid loss. Rapid rehydration can occur pretty safely for them. Think about Vibrio cholera, E. coli, rotavirus, and juice. Okay, high fructose load, high sugar load leads to diarrhea. All right, so it can be iatrogenic as well. Bloody diarrhea or dysentery, visible blood in the stools. Intestinal damage and nutrient losses. So think about your Shigella, your Salmonella, your E. coli, and other parasites. If they're persistent with or without blood lasting 14 days, think of malnourishment and worsening in underlying conditions. Prevention is the key, so good water sanitation and hygiene. Make sure everybody washes their hands real good. Micronutrient supplementation such as zinc, breastfeeding in kids exclusively less than 6 months of age. And then once again, rotavirus vaccine. So ORS for rehydration therapy, continue the feeding. So we usually try to breastfeed these babies through it. If they're breasts or if they want to eat, they can eat. So there's nothing really about using the brat diet or just giving fluids and not letting them eat or anything like that. Usually you don't have to do that. Sometimes these patients don't want to eat, right? Probiotics. So that's the one thing I would say. So yogurt is actually pretty good. So it recolonizes their gut so they can have yogurt even if you want to put them on a lactose-free diet. Think about doing yogurt at least once or twice a day. And then you can give medicinal probiotics. They're still pretty expensive here, but it's becoming more common practice. And then we use zinc for 14 days, which is pretty common. This rash is from candidiasis, psoriasis, scabies, or staph scalded skin syndrome. Right, just a diaper rash, right? All right, candidiasis caused by a yeast, candida. You can see the pseudohyphae if you do a prep, can be normal flora. Thrush is when it's in the mouth. Think about infants, think about immunocompromised people. Oral nystatin or clotrimazole can be used to treatment. If mom has erythema around her breast and some of those things, you may need to treat her breast as well for breastfeeding babies with topical nystatin. Gentian violet and boil everything. So keep in mind, if the baby's eating with a bottle, you don't boil that bottle. They have thrush. They keep using the same bottle without boiling it. Then they keep reinfecting themselves with the thrush. Okay, so you got to disinfect really once a day as you're starting treatment. Okay, diaper rash, gluteal folds, neck growing, axilla, topical antifungals for that. What is the cause of this rash? Dewdrop on a rose petal, measles, scabies, staph, or varicella? Varicella, right? Good. So varicella zoster. So if a mom's pregnant and she obtains varicella, then the fetus can come out with hypoplasia and CNS damage. It is one of the torch infectants that we think about sometimes as well, right? Primary illness is chickenpox. Secondary illness and shingles. So generalized pruritic vesicular rash, it varies in stages until you have crusting over of all the lesions. That's when they're getting truly better. Can lead to complications such as varicella pneumonia, CNS meningoencephalitis, and superinfection with bacteria. Secondary illnesses and shingles, especially in immunocompromised children, can be systemic and severe. It's usually localized in a dermatomal distribution. So this little child here with chicken pox, incubation's around 2 weeks. Direct contact and airborne, isolate until there's no new lesion. So airborne, I didn't tell you about. So if not just touching the rash, they actually will spread the rash via their droplet secretions from sneezing, breathing, coughing, those kind of things. So you need a mask on if you go see them. Once again, if you're immunocompromised or pregnant, do not go into a room with a child with varicella, okay? Because it can be very harmful to your baby. Oral acyclovir in pregnancy, IV antiviral for immunocompromised patients. Don't give salicylate because of Rye syndrome, right? It's an old illness. I haven't ever seen Rye syndrome myself. It's something for you to know for testing purposes and read about. Just make sure they don't have aspirin, okay? Vaccine at 1 year and 4 to 5 years. Update vaccine in adolescents if needed. What is the most likely cause of this rash? Eczema, scabies, sunburn, or vitiligo? Yeah, eczema, right? Atopic dermatitis, once again, is an Ig-mediated type 1 reaction. It's associated with allergies as well as asthma, chronic relapsing intermittent skin inflammation. So babies usually have it more on their face and extensor surfaces. Older children have it more in their flexor surfaces. Teens and adults can get it on their hands, all right, and their feet and their flexor surfaces as well. Can have complications of infections and scarring, so you do want to treat it. You want to avoid triggers. Can be oral foods as well as other topical triggers such as harsh soaps and some of those things. Emollient is the mainstay of treatment, so you put emollient, some type of Vaseline or something like that, head to toe 1 to 3 times a day, and then apply topical steroids to the very severe areas twice a day for up to 7 days. So after about 7 days, especially in darker skinned individuals, they can start losing their keratinocytes and turn white in that area. All right, they will reestablish keratinocytes there, but it may take a few months. So you do want to, after about 7 days of topical steroids to one location, you probably want to take a break for a few days and just kind of let it rest and then restart it. What is this itchy red rash? HSV, eczema, scabies, or mumps? Scabies. Everybody start scratching. All right, once again, 7-year itch. Okay, the burrow is rarely ever seen. Wrist, ankles, abdomen, interdigital areas, okay, along the waistline, those kind of things. Anywhere there's tight compression of the skin, the scabies like that because it's hotter there. Occurs on the face and scalp in infants, vesicular component in children. You want to treat all family members and all bedding and clothes and things like this. It's highly contagious, so everybody just needs to be treated all at once if you can. Use permethrin 5%. You cut the fingernails short just so that they don't cause excoriations when they're scratching because they're going to scratch. Repeat that treatment in 10 days. Lindane can be used as well as sulfur if you need to. All right, what is that growth? Lipomas, acne, warts, or molluscum? Molluscum. You'll see a lot of molluscum? Not too much here, huh? Yeah. So molluscum. Contagiosum is a pox virus. It's a human reservoir. Once again, it can be contagious. We usually let these things just go away. Usually they're benign, asymptomatic. Sometimes children will scratch them accidentally and they'll bleed a little bit, but usually they go away if that happens, so it can be a good thing. HIV and immunocompromised can have very widespread, prolonged eruptions. They're usually flesh-colored, translucent in color, dome-shaped papules with central umbilication. So you see that there, right? Dome-shaped papules with that depressed center. Self-resolves, you can remove them, burn or freeze them. I have a theory that Nairobi flies, which are very prominent right now, I have a feeling that if you put that Nairobi fly juice right there on top of the molluscum, it'll probably go away after a few days of treatment. Okay, so cantharidin and imicamod. Y'all can try it. You got enough, right? Try it. See. All right. Removal, burn, or freeze them if you need to. But once again, it's usually a pox virus. It usually will go away. It can take up to 6 to 8 months, and it just really depends on where it is. So, any questions? Any concerns? Anything we talked about? Oh, that was a lot, really fast. Y'all obviously will have this uploaded to the drive for medical education purposes, and so we'll go from there. All right. Thank you.